Thank you to Carlos and to the Pulver-TAF group and the BSSH for helping this out. And I'm very honored to be here tonight, and we spent some time talking about the spastic upper limb. I work at the Institut de la Main, and you can see it's just halfway between the Eiffel Tower and the Arc of Triumph, the ideal place. And actually it's quite nice. So we start with a definition, and I always come back to an old definition by Lance, which defines it as a motor disorder characterized by an increase of the stretch reflex, and it's easier to understand it as an increase of the muscle tone and exaggerated reflexes amounting to a clonus. So we have an increase of the muscle tone. This is what we want to remember. This is quite a difficult subject, and one of the reasons is because its clinical presentation is can be very different, and is quite complex. So we're going to try and go through this. What causes spasticity? Well, there are several etiologies, several causes. Of children with cerebral palsy, 85% of them are said to have spasticity. Another cause is head injury, and that's mostly young adults. Stroke is mostly older adults, and 30% of them are known to have spasticity. And we find also spasticity in a number of cases of tetraplegia, mostly in the lower limbs. But if the tetraplegia is incomplete, it's quite frequent to have spasticity. There are other causes such as multiple sclerosis, etc. So we must remember that the cause of spasticity can lie either in the brain cortex or in the spinal cord. Some people tend to forget about that, and this is also known as the upper motor neuron syndrome, which is a little bit difficult to understand for non-English speakings because we don't always use these words. Anyway, so we're going to spend the first part of this talk on clinical examination. This is extremely important because if you want to treat those people right, you need to understand what's going on. You need to understand what's wrong, and this is done mostly through clinical examination. So this is not done as a single individual in the usual setting. We try to gather and examine those patients together. There is the medical doctor taking care of them, whether physiatrists, neurologists, pediatrician, physical therapists are an important part of the group. In France, occupational therapists, and I think you have them also in the UK. In some countries, it's not so separate. But to me, the occupational therapist is a very important part of the team because they spend a lot of time with those patients, and probably those are the ones who know who know best, you know, what are the problems and how we can help. And of course, the surgeon is only part of the team, and I would certainly not put the surgeon at the head of that team. When we're doing the examination, we need to be in a specific environment. It needs to be quiet. It needs to be warm. This is important because we know that spasticity is likely to increase with a number of circumstances, and emotion is one, fatigue is one, cold temperature, etc. So you really need to have a quiet environment. You need to have time. You cannot examine a spastic patient in 5 minutes. This really takes time, and provided this is done, I think we can get a lot of information from the clinical examination. We never embark into surgery after a single examination. Again, spasticity varies, so it is important to see the patient several times in order to have a better idea of what we need. We tend to do a lot of recording of our clinical examination. We try to use standardized charts. This is one. There are many. I think the important is to design one that you like. And we do a lot of video recordings. This is especially important in children. Children, you cannot spend half an hour examining a child. So before the examination, usually the occupational therapist has done videos, and we look at the videos together before the child even comes into the room, and through that we already have a good idea of what to look for and what we are actually going to examine in the child. You see here the ideal setting is when you have two cameras at right angle, one from each other, and that allows you to see a lot of things. A very nice third camera that my occupational therapists have designed, or not designed, but have done as a third setting, is putting a camera underneath a transparent table and looking at how the patient, this is a child here, grabs object. And you see here how well you can see the thumb. The thumb is always difficult to examine because of the pronation deformity. And here is quite a neat thing to do. So we use that a lot. So first, what we're going to do is examine the patient at rest. Spontaneous posture gives you a lot of information. The typical picture is in shoulder adduction and internal rotation, in elbow flexion, in wrist flexion and pronation, and in children, often in ulnar deviation. Why children in ulnar deviation? Because of the FCU, of course, but I'm not sure why the FCU should be more spastic in children than in adults. For the fingers, the picture can be very different. In the center, you see this is the typical wrist flexion, finger flexion deformity, but you see that you have a whole lot of other different types of deformity: swan neck, intrinsic contracture, pseudo-boutonniere type of deformity, wrist extension. So everything can be seen. And so this is what we were talking about earlier. You know, spasticity is variable and will lead to very different deformities. For the thumb, the typical posture of the thumb is in adduction, and sometimes in flexion adduction, amounting to the thumb in palm deformity. Tonkin has made a nice classification of categorizing the intrinsic type. He's called it type 1, extrinsic, so this is flexor-pollicis longus type, and most often the type 3, which is a mixed type. So what we are going to try and find out during our clinical examination is what is the cause of the deformity. And then once we have identified each of those causes, we will be able to treat them. So obviously spasticity is the main, or at least the first deforming factor. We all know its main characteristics. It's mostly involving flexor, adductor, and pronator muscles. It resists stretching, but finally yields. That's important, with a return to initial posture, and it is accompanied by hyperreflexivity. Well, there are many problems with spasticity, and one of them is to evaluate spasticity. The most used scale is known as the Ashworth scale, modified by Bohannon in 1987. But if you look into it, you see no increase, slight increase, more marked increase. And you realize very easily that this Ashworth scale is not very objective, and it's very much evaluator dependent. And you see that Floren in 2010 named his article "Stop Using the Ashworth Scale." Another interesting scale was designed by a French neurologist, Tardieu, and that was many years ago in 1984, except that he didn't speak English, didn't care for English, and it's not until recently that this has been known. And Tardieu scale is based on what we call the angle of catch. And I'm going to show this to you right now. And you see, oops, I'm sorry, that's a bad move. I'm going to try and go back. And here we go. And the angle of catch is with high velocity, you see when the catch takes place, and we measure that angle. And there are also other measurements. The type of catch is important also. And finally, evaluating our patients, we have found that the combination of Ashworth and Tardieu scale is the best way so far. Maybe we'll find better ones later, but so far is the best way to evaluate spasticity. However, there are many things that mimic spasticity, and we're not sure how to call them. I've put a certain number of names here, but some other people will call them with other names. There is rigidity, there is hyperviscosity, there is force generated by active muscle fibers, and sometimes it's quite difficult to make sure that we are indeed dealing with spasticity. And Dystonia will talk about that in a few minutes. Excuse me, the second cause of deformity is muscle contracture. It's quite easy to understand that a spastic muscle with permanent or very frequent contractions of the muscle will end up shortening, and some contracture is going to develop. To the difference of spasticity, it does involve, of course, the same muscles, but it is permanent. It cannot be overcome except by shortening the articular segment when you have a bi or tri-articular type of muscle, such as the finger flexors. The problem is that spasticity and contracture, of course, are very often associated, but we need to distinguish them because we will see that they have a different treatment. We get some help from some substances, and namely nerve blocks and muscle blocks, because when we apply these blocks, spasticity is going to yield, whereas contracture persists. So in severe cases of spasticity, this is extremely interesting. Finger contracture now we can evaluate through the well-known angle of Volkmann. So this is a minimum wrist flexion which is required to obtain full extension of the fingers. You see here it's been measured at 75 degrees, so it's a pretty nice evaluation. Now on to the intrinsic muscles. We don't have time to go into details in the contracture, but let's remember about the phenoketose test. When the MP joints are in extension, if you cannot flex the PIP joint, there is intrinsic contracture. On the contrary, when the MP joint is in flexion, sorry about that, when the MP joint is in flexion, you can easily flex the PIP joint. So remember, when the MP joint is in extension, if you cannot flex the PIP joint, you do have an intrinsic contracture, and this is important in those patients. Joint deformity would be the next cause of deformity. It is not very frequent in children, neither is it in adults. The difficulty about joint deformity is that if there is muscle contracture, you will only be able to assess a joint deformity on the operative table, once you have gotten rid of the muscle contracture. So this is sometimes a per-operative surprise. The other type of joint deformity is hyperlaxity. We see that mostly in children and mostly at the level of the finger PIP joint and the thumb MP joint. Last but not least, the last cause of the deformity is the muscle imbalance. Imbalance between the spastic muscles, which are usually active, so they are spastic and active, though they are mostly the flexors and the pronators. And of course, their activities, their strengths may be quite difficult to assess because of all the surrounding deformities. Look at this young 8-year-old girl with his flexed wrist. Well, with a hyperflex wrist, it's very difficult to test finger flexors. On the opposite, the non-spastic muscles, we're talking about the extensors and the supinators, are known to be often paralyzed. And you see here, I've written pseudo-paralyzed because sometimes they're not paralyzed. They're just prevented to be active because of the antagonist muscles, which are so spastic and pulling so hard. So part of our goal is going to find out what is the value of those non-spastic muscles. Are they indeed paralyzed, or do they just need releasing the antagonist in order for them to so-called wake up and be active? This is, of course, very important. So again, difficult to assess. And then we have a number of things which are associated. And if you look at this hand, it's quite hard to understand why these fingers move differently. Index and little finger different from third and fourth finger. Well, there are apparently several reasons to that. There is paresis of the EDC, which is greater than the paresis of the EDP to second and fifth finger, but mostly there is probably spasticity of the finger flexors and the interossei that account for this. So you see, we can spend quite a long time on this clinical examination in order to understand what's going on. And finally, in children, there is one thing that really needs to be taken into account, because this will usually be a contraindication to surgery, and that's dystonia. You see this little CP child, she has a left hemiplegia. She's now trying to move her left arm, and you see how difficult it is for her, and what poor control she has on those involuntary muscle contractions. And of course, with this kind of dystonia, surgery is not indicated. You will not get anywhere with this type of dystonia. Here it's quite obvious, but sometimes it's milder, and you need to be careful about dystonia in children. So what other tools do we have that could help us assessing that spasticity? EMG study, well, EMG studies don't help much, and I must say I'm not using them very much just to assess the value of a muscle. EMG studies will tell you if the muscle is active or not, but it won't give you much quantitative information. On the other hand, it can be very helpful when we intend to do a tendon transfer, and then we will do dynamic EMG studies. We'll come back to that. But the thing that is mostly helping us for diagnostic purposes are nerve and or muscle blocks. I use muscle blocks rather than nerve blocks. It's quite easy to use, and its action, as you know, lasts several months, at least 2 or 3 months. And so during those 2 or 3 months, you really have time. You have time for what? Well, you have time to evaluate the contractures, as we said, but you also have time to assess antagonist muscles. As I said earlier, you know, those antagonist muscles, those extensors and supinators, which seem paralyzed. Well, once you have put some toxin botulinum toxin, in the spastic muscles, then you can start moving them, activating them with the physiotherapist, and then you may have the good surprise of seeing them be active again. You can also assess spasticity of other muscles, and this is especially true within intrinsic muscles of the hand. If you have a tight fist because the finger flexors are so spastic, there is no way you can examine the intrinsics until you have paralyzed temporarily your finger flexors. And so this botulinum toxin is going to be extremely helpful in the pre-operative planning. And I'm going to show you an example of that right now. But just before that, I wanted to tell you that it's extremely rare that we nowadays operate any patient without doing a pre-operative botulinum toxin. So here's this nice boy, and he's a cerebral palsy left hemiplegia, and he has spasticity in his thumb adductor, which is preventing opening of the hand. And so we wanted to test this muscle, and by applying toxin in it and seeing how, if he performs better. Unfortunately, he put his best t-shirt for the first examination, and he put the same best red t-shirt for the second examination. So you're going to have to follow that quite carefully, but I've put some little tags here. So he's performing what's called the AHA test, where the child has to perform a certain number of activities, it's playful, and he's not told how to perform them. He's just asked to perform them. So here now we are post-toxin, and we go on to the next activity where he has to open this little bag. And you see here, before toxin, his hand is used only as a press. He has no kind of grasp, and he has found himself now, after the toxin, that he can use it. And the best example is here, opening the bottle and putting some marbles in the bottom. So it's a bottle. So here, pre-toxin, he cannot, perform very well. He doesn't have the capacity to hold the bottle straight. And now, after toxin, in his thumb adductor, you see things become much more simple, and he can perform this task quite easily. So with just the help of this botulinum toxin in one little muscle, we know what to do now. We need to diminish spasticity in his thumb adductor. After motor examination, of course, we want to examine sensation. Usually basic sensations are intact or pretty good, whereas complex sensations such as proprioception, stereognosis are altered. If basic sensation is intact, we don't have to worry too much, but if it's severely altered, then this may amount to a contraindication, at least to functional surgery. Functional examination, this is a whole chapter by itself, but we will have to go quite fast in that. Let us remember that we want some tests that will tell us about grasp, pinch, and release. Release is a big problem in many of these patients, and so we need to see how they perform also in release. And you see, we use different objects of different sizes, shapes, and weight. Bimanual activities are very interesting because they have to use the involved hand, especially in hemiplegics, and I like those Russian dolls, which are quite nice. And there is also some cognitive testing with the Russian dolls, a number of complex tasks, and time recording to achieve the task will help. And also very important for children, ADL questionnaires. Children like to perform in front of the examiners, they like to please us, and so sometimes they're going to use their hands, especially hemiplegics, in a quite nice way. But then if you talk to mom says, oh, but doctor, at home, he or she never uses it, and always keeps it in the pocket. So you need to understand that and to evaluate that if you don't want to have a bad surprise at the end of the day. So there have been many tests, there have been many scales which have been described. Some are mostly analytic, some are both analytic and functional, and here I've shown you the box and block test, the 9-hole peg, and so forth. Some are purely functional, like the AHA test I showed you earlier. What you need to do is choose one or choose several. Sometimes we need to choose several and stick to them. So this way, you're going to be able to evaluate your patients pre-operatively and compare them to the post-op and compare them between themselves. I like the House classification designed by Jim House in 1981. It's very easy, simple to perform during the clinical examination, and it just gives you a rough idea of how much the patient uses his or her hand. Of course, we have to remember that those spastic patients do have other impairments, and so this must also be evaluated. Lower limb in hemiplegic patients, upper functions can be also impaired. Beware of vision defects. That's going to be a big problem for them. Extrapyramidal, they have epilepsy. Apraxia can be a big problem, and this is a difficulty with planning a movement. And also the cognitive impairment, although cognitive impairment to me and to many others is not a contraindication even to functional surgery. Other factors are important. Look at this, this young boy. He has this very severe wrist deformity on the left side. We need to operate on them, but look at him. During the whole of the examination, he did not stop moving, spit on people, call people names, and was all over the place during the whole session. So you need to take this into account. You need to adapt your surgery. You need to adapt your post-op, even though you have to do something with them. Environment, children, you know, are mom and dad going to be around, take them to the physiotherapy and so forth. Motivation, some patients are depressed, especially when you deal with stroke patients and don't care about improvement. On the other hand, some patients have great expectations, and we need to beware of teenagers with cerebral palsy. Those kids, you know, usually have a good, are well taken care of during infancy and early age, and then they get tired, they don't see any more improvement, and usually they disappear from our radars. And we see them coming back around 14, 15, 16. And we need to understand why they come back. And usually the thing they want a hand or a limb that looks normal. They don't care about function anymore. They care about aspect. You know, they have friends, they have girlfriends, and they're tired of this arm coming up all the time. And so you need to hear that because you can help them, but you need to hear that they don't want function, they want cosmesis. So to close this first part of our talk, remember that clinical evaluation needs to be repeated. It needs to be performed as a team, and this way, we will be able to select the proper candidate. And let me have a little bit of water. And so we'll go on with surgery, and we will deal with the principles of that surgery of spasticity. And first, a question: what can we do? What can we improve? Well, there are some things like spasticity, muscle contracture, joint deformity that, of course, we can impact on. Muscle paralysis, well, maybe if we can find a muscle to transfer to get rid of the paralysis, but some other things such as sensory deficit, and that's been said before, dystonia, there is no way surgery itself can have any effect on that. Most important is, what is our goal when we're treating these patients? And roughly there would be three main goals and a fourth one. Of course, we're trying to improve function. Every time this is possible, we will improve function. But on many occasions, function is not the goal. Look at this patient. He has severe cognitive problems. He's bed wound, and all we need, and all the family wants, and all the nurses taking care of him want, is a better alignment of his upper limbs so they can take better care of him for nursing, hygiene, and decrease the pain. And of course, here we're not dealing with function, but we need to take care of that also. In other patients, and we talked about the teenagers, it's going to be cosmesis, that's important. And again, we need to hear what they want and then adapt our surgery to their requirement or to their desires. There is a fourth goal, which we must be quite careful about, is prevention of orthopedic deformities. This is important, especially in children. And Carlson in 2014 showed very clearly that there was a direct correlation between growing age and the degree of contracture. And if you let a contracture develop after 12 years, you see that they are 5 times more likely to have fixed elbow contracture than under 12 years of age. So in a small child, if you see some contractures start developing, one needs to intervene quite early in order to avoid fixed contracture. If we're talking about functional surgery, what is our goal? What is the concept? Well, the concept is to restore the balance. Restore the balance between those spastic muscles, usually the flexors and pronators, which are spastic and, which have spasticity and muscle contractures, and to reinforce the control of the opponent muscles, the extensors, the supinators, which are either paralyzed or pseudo-paralyzed. So you see right away that we are likely to do multiple procedures. And these multiple procedures, we try to do them all together in one session, at least on one area, on one joint, because it doesn't make sense to reduce spasticity if you don't reinforce the voluntary control, because spasticity and or contracture are likely to recur. So reduce spasticity, how do we do that? We've talked about nerve blocks, we've talked about botulinum toxin. Is there a way we can do that surgery? Certainly. And this is called partial neurectomy. We all know about complete neurectomy, which is going to make a muscle paralyzed. But here we're talking about partial section of a nerve. So we're dealing with motor nerves, and our goal is going to reduce the spasticity, but without suppressing the useful muscle tone. And of course, this type of surgery is indicated only in spastic muscles without muscle contractures, or you need to add other procedures to get rid of the contracture. Stoffel, many years ago, had shown that by doing partial neurectomy, you could indeed achieve that goal. A technique has developed mostly through our neurosurgeon colleagues, which is a truncular technique. So they approach the motor nerve at the trunk level, as you can see here, and with the help of electrical stimulation, they identify the fascicles for the muscle they want to treat. And once they have identified the fascicles, they resect part of those fascicles. The advantages of this technique are a limited approach, as we can see here. The problem is that identification of those muscles and the nerve to the muscles relies only on electrical parameters, and we know that sometimes it's not so precise because of the variation of motor branches, and so some of those nerve branches may be missed. And also another really problem is that some sensory branches might end up getting cut, and this leads to some postoperative pain, which is sometimes really bothering. Brunelli, our Italian colleague, well known, who unfortunately deceased last year, found a better way of dealing with that by approaching the fascicles all the way to their entry into the muscle. And there you cannot go wrong. You identify very precisely which branches go for which muscle, and then you can do a partial resection of those branches. Usually partial resection is 2/3 of the motor branches. Sometimes you can do less, but not much less. It's been shown on many occasions that less is not very effective, but sometimes you can do more if required. So we have pushed this technique very much in our group, and termed it hyperselective neurectomy. You see this is a dissection of the musculocutaneous nerve, and you see how we follow each of the little branch and each of the rami of those branches going into the muscles. And this is where the neurectomy is performed. You can see here in the living, these are the 4 branches for the FCR with the median nerve on top. And you see that you can dissect that quite nicely, of course, with surgical loops and microsurgery instruments. And then you can perform a very nice resection of how much you need to resect. So before embarking on that, we did a large number of cadaver dissection, and we performed a mapping of each motor branch. This has been published in the literature, and so now we have a pretty clear view of each motor nerve and their branches. There are indeed many variations, so you need to go through that if you want to do this surgery. However, we do get extra help from per-operative stimulation, which we use all the time. And in case of doubt, this is going to be very helpful for those surgeries. Very briefly, we have just finished a large prospective study of 65 patients, and this is in press. We hope this will come out in our favorite journal very soon. So there were 65 patients, 20 children, 45 adults, with an average follow-up of 30 months. You see that amounts to a great number of muscles that were neurectomized, 219. I will not go into the details, but mostly elbow flexors. And I just want to show you our results summarized on this table. You see, we've looked at pre-operative measurements at 6 months post-op, and at last follow-up to see if the results were I'm sorry, I cannot find my word, but could be trusted in the long term. So you see that the spontaneous, and these are the results only for the elbows. I'm not going to show you the rest. So you see for the spontaneous posture, quite nice improvement, and that's durable. That's the word I was looking for. Range of motion, whether active or passive, does improve, but moderately. It is significant, but it's moderate. We don't gain much motion, whether active or passive, with those techniques. The great news of this work, and it's been said before in the literature, is that there is no loss of flexion. So you do cut 2/3 of the motor branches to a muscle, and in the end, it does not lose strength. And this was very reassuring. And of course, the antagonists have a tendency to gain strength, but this is not surprising. And now finally, the spasticity measurements. You see that all of the spasticity measurements have improved, with, however, a slight tendency to relapse at last follow-up, but this seems to be quite stable in the long term. Function improves to some extent, and satisfaction of the patients is quite high. So this hyperselective technique is indeed effective on spasticity. I would say that it displaces range of motion rather than really bringing great improvement in active motion. No loss of strength, improvement of the strength of the antagonist. slight relapse of the spasticity at long term, and high level of patient satisfaction. This is a result of this technique, and this young boy had hyperselective neurectomy of the musculocutaneous nerve and the median and all the nerves for the wrist. And you see this is a boy with only spasticity, no contracture, and we can end up with satisfactory results. Next deformity that we may need to correct is muscle contractures. And you see that there are a number of techniques which have been designed for releasing muscle contracture. We probably know all of them. Of course, tenotomy is an easy going solution. It's performed mostly for the FCU, pronator teres, and biceps. Think twice before you cut a muscle. Make sure that you could not be needing it for a tendon transfer. So just think twice. Rather than a simple tenotomy, we like to perform tenectomy to make sure that there is no scar forming in between the two ends. For the wrist flexors now, there is quite a popular medial epicondylar release. One must be a little bit careful about the environment, environing, nerves, not only the ulnars, this is obvious, but also the median nerve, which is not so far away. This is an operation which has been said to induce some loss of strength of flexion, because when you let the muscles go down distally, you do not control how much slide takes place, and you might get some quite important loss of flexion unless you decide to attach the muscles to the skeleton, which could be one solution. Zancoli has designed a very nice equivalent of medial epicondylar release that he uses mostly in children. And instead of detaching the muscles from the bone, what he does is doing an aponeurectomy of all the envelopes of the medial epicondylar muscles. This does not amount to as much release as the former operation, and so we in our team reserve it mostly to children with moderate contracture of the wrist flexors. And if there is contracture of wrist and finger flexors, well, then there is a big Scaglietti page operation, the big forearm slide, named after Scaglietti, Italian surgeon, and Page, a British surgeon. And or maybe I'm wrong, and somebody will tell me he was American. Somebody will have to help me on that. And so you see this huge operation starting at the elbow and going all the way down the forearm and detaching everything from the skeleton. This is a big operation. It does give satisfactory results. This is a head injury, 20-year-old female, and she had both wrist and finger flexor contracture. And you see the excellent result at 6 months post-op. However, this, as we said, is a wide dissection. There is a hematoma. The anterior interosseous artery is at great risk. And there is also, through this technique, muscle weakening. I must say that I myself have pretty much abandoned this technique for spastic cases. And every time this is possible, I prefer to turn to tendon and or muscle lengthening. So the lengthening towards the distal end of the muscle can be performed inside the tendon, intratendinous Z-plasty. The problem with this is that this requires sutures and probably post-op immobilization for the scarring and union to to take place, and we prefer every time it's possible to use lengthening at the tendon muscle junction. However, some muscles with a very short overlapping of the tendon and the muscle cannot be treated this way, and we do need for the biceps and the FCR, namely, we do need to do mostly intratendinous release. For most of other forearm and hand flexor muscles, we can use this fractional lengthening. And you see on these pictures that we are able to do many fractional lengthening. If you look at the old textbooks, they would do one or maybe two, but you can do more than that. You can do more than that, provided that you know how much overlapping there is of the muscle and the tendon. And we did last year, and this is also should be published pretty soon, a cadaver study for each of the forearm flexors. And we determine what we call the useful zones, the red arrow that you can see here, for each of these muscles. And indeed, this useful zone can be very different. For example, for the FCU and the FCRs that you see here, I just mentioned that the FCRs, this is quite impossible to use this technique. And it comes out from this work that some of the muscles, namely FCU, all FDPs, FPL, and FDS of the third finger can be lengthened this way. All of the muscles, you need to watch, to look at the muscle before doing lengthening, because this overlapping zone is short. Recently, we have done more and more combined procedure of spasticity and contracture. As time is running, I will not go into this, and we should be publishing this also hopefully pretty soon. But you see this patient, he is a CP patient. He has both important spasticity and important contracture. So we did hyperselective neurectomy at the same time as lengthening of his elbow flexors. And this is his spontaneous posture to the left. And this is the great improvement to the right. So just to tell you that we don't have to choose in between all these procedures. We can add them if spasticity and contracture are both present. Another means of lengthening the finger flexors has been designed by an American surgeon named Braun, and this has been referred to as the STP procedure, superficialis to profundus, and this consists in a distal section of the superficialis muscles, proximal section of the profundi, and we just suture those two ends together. So which amounts to a very nice lengthening of the muscles with some continuity. Of course, this type of surgery will amount to a limited active flexion, and we reserve it mostly for non-functional or poorly functioning hands. In some cases, the wrist, and it's mostly the wrist, can be extremely contracted with severe deformity. Soft tissue procedures in this type of deformities are not enough, and we need to resort to wrist arthrodesis. In adults, this is done in the form of a complete arthrodesis. We usually do a resection of the first carpal row and a fusion of the radius to the second row, which gives a little lengthening of the whole thing at the same time. Rather than those big plates that you just saw here, we like to use nowadays smaller plates, which are much easier to apply to those very unusual, let's say, wrists. And so this is where we perform resection of the proximal row, as I said, and fusion of the radius to the distal row. That requires, in most occasions, also some lengthening of the finger flexors, because when you bring the wrist back into a straight position, your finger flexors are going to be much tighter. So you need to take care of that and do those lengthening at the same time. In small children, there may be a need in a few cases to do a bone procedure when they have extremely severely flexed wrist. Rather than doing a complete fusion, we have been happy with mediocarpal arthrodesis, which leave the radiocarpal joint and the growing plate intact. And that's quite nice, and it helps holding them in a pretty nice position. Third and lastly, the voluntary control. So if there is paralysis and if we want to reach some function, then we need to bring back some voluntary control to this paralyzed antagonist. And of course, this is done mainly with tendon transfers. But how can we do tendon transfers once we have explained that muscles are either spastic or paralyzed? Well, we can transfer spastic muscles, and this has been shown very nicely by Hoffer from Los Angeles many years ago. You can transfer spastic muscles, provided, of course, it has a voluntary control and it is strong, but also that it has the ability to relax. This is what we call a phasic muscle, and this is where dynamic EMG studies are very helpful. And you see here on this graph, the FCU on the bottom line is phasic. It has the capacity of relaxing. Otherwise, this is what happens. This is a young girl I operated many, many years ago when I did not understand this. So I transferred a spastic FCU and made it into a spastic wrist extensor. And of course, she was not better off with this muscle that was not phasic. So the choice of donor will, of course, depend on your clinical examination and the EMG studies. It can be mostly for wrist extensor and FCU, finger superficialis, etc., but it can also be a brachioradialis and so forth. So it is the best muscle that we will choose. Just a word about tendon transfers in children. This has been shown many years ago that when doing tendon transfers for wrist extension, and here the choice was the FCU to the ECRB, the best results were in patients who were between 7 and 12 years ago. So if you want to do tendon transfer in children, do them early. This is a result of such an operation at 3 months post-op. And you see that the transfer here, this was a brachioradialis muscle. The transfer is quite nicely active and performing. So we will be doing a lot of combined procedures. We try to perform them all together whenever possible. But if we have to deal with several areas, several joints from the shoulder all the way to the fingers, if we have to make a choice, we will usually start with the most severely deformed joint and also with the elbow before wrist and hand. We will go from proximal to distal, and I like to end up with a thumb, which position will be adapted best when we know how the wrist and the fingers are dealing. I will end up very briefly with a few examples to show you all the different types of patients that we have to deal with. And this is a bedbound patient with severe cognitive problems. He's 62 years old, no communication, and terrible contractures of both shoulder, elbow, wrist, and fingers. He's at home with his aging wife, and nursing is difficult. He cries every time one moves his joints. And so our goal here is only pain, nursing, and hygiene. So what we're going to do here is a lot of tenotomies at the level of the shoulder, at the level of the elbow, and at the level of the wrist and fingers. Here for the fingers, we did the STP procedure, and you see before and at the end of surgery. We try to deal with both arms at the same time in these patients. And this is not very, should I say, rewarding surgery, but it's extremely helpful for the patient, the family, and the caregivers. On the opposite, this is another stroke patient. He is 62 years old, and he has this strange spasticity in extension of the elbow, which is unusual. And you can imagine how difficult helping the patient to get dressed and all the nursing are uneasy and difficult with the elbow permanently in this extended position. And clinical examination showed that indeed spasticity was isolated, there was no contracture. So we decided in this particular case to perform hyperselective neurectomy of the motor branches of both triceps muscles. And although our goal was only nursing, I'm sorry, I did something wrong. So sorry. Well, you're going to have to believe me on that. He regained some very nice active flexion of the, oh, here it goes, of the elbow. Something is not working well here, I'm sorry. And next thing he asked was some improvement of the hand, because now with a functioning elbow, he could hope for some function in the hand. And last case is a 12-year-old cerebral palsy child. He has a usual spontaneous posture in pronation with flexion, some adduction. Here we obviously have a functional goal. So we did a number of procedures at the same time. There was spasticity of the pronator teres. The choice there was a tenotomy. He had spasticity and contracture of the wrist flexors with paralysis of the extensors. We did lengthening of the flexors and the transfer of the brachioradialis to the wrist extensors. And for the thumb, we did an opening of the first web. So here he is, and we're going to see his result at 9 months. And this is left hemiplegia in 12 years old. Now he's 13, in a 12 years old boy. And you see 9 months after surgery, this is pre-operative, and you see this grasp, which is really rudimentary, not very precise. And that's him after surgery. So you see the change in the wrist position, the fingers opening, and the thumb position. What you see also in these pictures, this is pre-op. What you see also in these movies is that he is extremely concentrated on what he is doing. You can tell 9 months after surgery, this is not yet very automatic. And again, that's why another argument for offering this type of surgery to children quite early. We're gonna close this. And so as a conclusion, we talked about clinical evaluation already. There is no such thing as a standard procedure in this surgery. We want to try and restore the balance. In children, we try to operate early, and I must say that this surgery is not a very easy surgery, not for the techniques, but mostly for the decision making. For those who are interested, Donald mentioned the masterclass that we do yearly.